Introduce our four speakers. Our first, just go ahead and we can launch right in. I don't exactly know how best to do this. All right, our first speaker is Alan Labreque. He is from Johns Hopkins University, and he's going to be talking to us today about mobile phone ownership and widespread mHealth use in a very large number of women of reproductive age in rural Bangladesh. So without further ado, Alan.
Thanks. Good morning. Can we turn down the mics a little bit, please? Thank you. So it's a pleasure to be here, and thank you so much for having us on this panel and to be part of such a distinguished panel of speakers. Today, what I have the privilege of sharing with you is some data from our large field sites in rural Bangladesh, where we've been working now for over a decade, studying ways to affect the trajectory of mortality in pregnant women and newborns in this population. Basically, this slide explains why we do what we do. We're in the business of health. We're in the business of trying to save lives. In South Asia, across Bangladesh, Pakistan, Nepal, India, the equivalent of a Boeing 747 filled with new moms and pregnant women crashes every 2 weeks. This is the magnitude of the problem which we're currently trying to deal with. Finding health system strategies that can strengthen our ability to accelerate and reach scale with known interventions that can save lives in these populations where we deal with multiple challenges. Mortality, morbidity are geographically co-located. We look at South Asia, Sub-Saharan Africa as countries where the burden of disease, the burden of mortality substantially outweighs that in much of the developed world. This is the population in northwest rural Bangladesh where we've been working for nearly a decade, studying now almost 160,000 pregnancies in a representative rural population of the greater Gangetic floodplain in a district called Gaibandha. Over 850 field staff have, for the past 12 years, collected information on pregnancies on a weekly basis. So these 850 field staff collect about 300 new pregnancy data on a weekly basis, resulting in about 285 births on each 7-day period. So to give you a context of the challenges within which we work, we're talking about situations where 85% of the births in this population occur at home, far removed from clinics where emergency obstetric care can be provided. We're also looking at settings where about 50% of the newborns are born less than 2.5 kilograms. So low birth weight is a significant issue in this population. Furthermore, we see that about 23% of the population in this area are born preterm. So we're talking about individuals born in challenging situations. So irrespective of what this says up here, the real issue here is we're challenged on a number of levels: health systems levels, provider functionality levels, and the ability of clients to recognize danger signs and act on them in these rural populations. Next slide, please. When we zoom in to these rural areas where women are experiencing childbirth and trying to manage the survival of their newborn, we look at the change in trends despite massive improvements in the overall health systems in these contexts. We still see even an indicator such as skilled birth attendance in a representative rural population of South Asia has only gone up about from 5 to 10% in this population. Furthermore, when we look at care seeking for emergency obstetric care, emergency obstetric events in this population, we see that over 95% of that first point of care is to a non-certified, non-trained provider. And we think about that. These are situations of requiring emergency obstetric intervention, and yet that first point of care is an untrained local health practitioner. So how do we shorten the time between appropriate care and the incidence of a specific crisis? This narrative really reflects that dilemma that we face in these kind of contexts, where women are disconnected, where the health systems are, for many reasons, non-functional and unable to provide the kind of support needed by those women to survive that critical period of childbirth. In this situation, a number of opportunities were missed to provide that critical care to that woman such that she would have survived the pregnancy. So the challenge for us in the innovation space is to figure out how can we get physicians, how can we get care providers through appropriate methodologies, provide the necessary quality of care needed to ensure safe, clean deliveries and to ensure the maximum potential for survival for these newborns. It's not a question of whether we know what to do to save newborn lives. There are multiple guidelines that have been published by WHO, PMNCH, and so on, based on rigorous evidence generation for the past 3 decades. It's a question of delivery of those strategies to these resource-limited remote settings where these crises are happening. Next slide, please. So I've had the privilege of watching the mHealth revolution from the front lines. I lived in Bangladesh for 12 years running a large research trial there, and I kid you not, next slide, the solution for our telecom was going to be this carrier pigeon. We couldn't communicate 30 miles between 2 sites without actually writing a note on a piece of paper and dispatching a courier to hand it to the program officer in the next area. Cell phones in 2004 were a dream of the future that we had in this setting. Next slide. But not this one. Next slide. This was introduced in about 2005 and 6 by the Grameen phone company, and it changed the landscape of how we did health provision in these contexts. By the time I left Bangladesh in 2008 to come back to Johns Hopkins, we had faster internet connectivity in rural Gaibandha than we had here in Baltimore and DC. So it was quite frustrating to actually step down in technology coming back to the US. And today, in the field where we work, our 850 field staff all own their own personal phones, which is really a transformation that we've seen in this landscape. Next slide. So our data off these large prospective cohorts that we've been studying in various randomized trials to look at strategies to reduce mortality, because we're powered to look at mortality as an outcome, our sample sizes range from 40,000 to 70,000 depending on the population we're looking at. And so over the course of these 4 years, one could imagine the household level ownership of phones has increased from 20 to 45%. And this was data that I shared in 2010. Next slide, please. But when we stratify this ownership by socioeconomic status, this was a very interesting finding, that we see parallel growth in ownership across socioeconomic strata that doesn't seem to converge despite parallel increased growth in high and low socioeconomic groups. Now, why this is important, next slide. Next slide, please, is when we look at the converse, the burden of mortality, and we look at how that has been decreasing over time. Here we see neonatal mortality plotted again against those same 2 strata, and we see how despite improvements in both of these strata, there's the same parallel that we observe between where the problem is and where the phones are. Next slide, please. But access does not mean ownership. And many of us who work in South Asia or in Sub-Saharan Africa know that access to phones is now fairly ubiquitous. One can go to one of these small tea stalls where they're selling everything from biscuits and sugar to cigarettes and phone calls. So in an emergency, access to phones, as our next slide will show, is fairly high. This was from data from 2007 to 2009. 12,000 events of pregnancy were followed, and about 5% of women reported having a severe obstetric crisis such that they nearly died during that event. And what we found was, 50% of those who experienced those crises actually used a mobile phone. And the use cases were fantastic to see that they were calling a provider to the home, requesting advice, arranging transport, and requesting financial aid to help manage that crisis. Again, mHealth manifesting itself in the absence of formal mHealth strategies. Next slide, please. These 2 vignettes are typical exemplars of what we see reading verbal autopsies and near-miss narratives over and over again, how mobile phones served as a critical link to disrupt that trajectory towards mortality, away from that potential endpoint, where we see a mobile phone being used to gain advice from a distant provider or to mobilize the resources and supply chains necessary to get that woman to care in a timely fashion. Next slide. So our hypothesis has been whether the mobile phone in these settings are actually inflectors off that trajectory towards mortality. Whether we see, next slide please. Again, one more. Back one. Sorry. Whether we see the mobile phone actually deviating these trajectories by allowing individuals to organize transportation, call contacts, or use them to reach decision makers. Next slide please. Now, this is the study we just completed earlier this year in March, where we did an update household survey. We did almost 170,000 women surveyed to look at a whole range of indicators, including their ownership of phones. And now you remember, 2010, we had seen a 40% household ownership. This has now gone up to 71% in this population. Now, we asked them whether or not they had used a mobile phone to do any of the emergency health contacts that we had collected in the prior study, and in fact 20% reported that in the past month they had used a phone for an emergency health purpose. Now, what was interesting, we were able to then quantify the impact of household phone ownership on the likelihood of using a phone for an emergency health call. So phone owners were about 3 times more likely to use a phone for this emergency health purposes, that is, calling a provider, arranging care, getting advice, or mobilizing financial resources. Now, what I find especially interesting is the fact that the challenge that when we sit around a boardroom in Washington or Baltimore struggling through the fact that how can we implement these mHealth strategies where there's no electrical coverage, these have already been solved, because in rural Bangladesh, creative solutions such as battery exchanges, fee-for-service charging of phones have emerged to allow this level of penetration with only this level of electrical coverage. Next slide, please. So this gave us the courage to test new strategies. Could we, for example, identify women while they were going to labor? Now, why is that important? It's trying to predict when or respond to a potential crisis before waiting for that crisis to occur. All the formative work that we had done prior to this and that others had done pointed to the fact that women would conceal labor. Socially, culturally, labor was not something that was discussed openly in this context. However, when informed that we would be able to dispatch a trained nurse midwife team to the home to assist with the delivery if necessary, we were able to obtain 89% success rates to have families inform us when we're going into labor and to then dispatch those teams to provide that care in the home. Next slide, please. Next slide, please. And this has given us the ability to design systems that others have replicated and also co-developed in other contexts to allow simple processes that strengthen the health system infrastructure that allows us to deliver care, such as the fundamental registration of women who can become pregnant, to identify pregnancies and make this system accountable to deliver antenatal care when and where those care events are due, but then also enabling the families and the pregnant women themselves to elicit support when they need it from a responsive health system in this context. Next slide. We're using this to develop systems for vaccination tracking, where we're working with the government of Bangladesh to develop virtual vaccine registries, such that pregnant women or women in early motherhood can bring their newborns to a vaccination clinic and actually maintain a digital record of those vaccine contacts in a cloud-based system, such that these data are now accessible by physicians, by EPI workers, irrespective of whether that woman brings a card to that contact or not. Next slide, please. But fundamentally, as a public health practitioner, we see the world sometimes as systems. We like to deconstruct these systems as workflows and identify where in these workflows we can find pain points or opportunities for optimization. And this simple diagram actually reflects very common paradigms of health delivery in rural populations. We're talking about population enumeration, surveillance, the enrollment of clients, whether you're talking about new HIV cases or newly pregnant women, the assessment and intervention schedules that then have to be created to ensure the accountability for the delivery of those services are standard systems that can be presented on very simple mobile devices. Next slide. The challenge here is to move from this paradigm to a paradigm where data is meaningfully used at the point of care in the most remote rural settings. Next slide. So I'd like to leave you with this quote from Victor Hugo, which I think there is really nothing more powerful than an idea whose time has come. The challenge for us now in the research space is to generate the credible and convincing data that is needed for policymakers to make that shift from idea to implementation. Thank you.
Great. Thank you so much, Alan. We are going to move on to our next speaker. It's my pleasure to introduce Christine Lasway. She's going to be talking to us. She comes to us from FHI 360, and she's going to be talking about an evaluation of a family planning mobile phone job aid for community health workers in Tanzania.
Thank you very much. My slides also have animation, so let's see how that's going to work. Thank you very much for the opportunity once again. I'm actually presenting on behalf of our team from FHI 360, as well as Pathfinder, D3 International, as well as the Ministry of Health in Tanzania. And just let's see if this is working. Okay, we'll do this manually. Okay, next slide. So, as public health experts, our motivation is, of course, public health impact. And for our particular work, we're focusing on 2 Millennium Development Goals, and it's MDG 5 and MDG 6. And of course, as we all know, by 2015, the goal is to reduce maternal mortality ratio by 75%, as well as halt or reverse the spread of new infections for HIV. Next, please. So for the Tanzania context, next please. The Millennium Development Goal is to reduce the maternal mortality ratio from the current rate of 454 to 113. Sorry, the maternal mortality ratio. And as you can see, that's a 4 times reduction in just 3 years that are remaining. Next. For HIV/AIDS, I think we're doing a little bit better, whereby we have to reduce from 5.7% in 2010 to 5.5% by 2015. Of course, there's so many challenges that we are facing as a country to be able to achieve that, and we have a lot of work to do. But one of the critical challenges next is health worker crisis. Next, please. And of course, we know that at the global level, this is something that is profoundly affecting a lot of our health work globally. And we have a health worker shortage of 4.2 million. This is according to WHO in 2006. And next, in Tanzania, this equates to, next please, to 53,000 health worker shortages, which is equivalent to 65% of health workers that are missing, meaning that the health system right now is functioning at 35% health worker level, which is critically low. Next, please. So basically, community health workers, which is the focus of our mHealth innovation, we have been relying on them a lot to bridge the gap to our Millennium Development Goals. They perform multiple functions, including visiting households, promoting sexual reproductive health education, providing services, as well as monitoring and following up clients. However, they do face a lot of challenges, as we all know. Next slide, please. Now, just to choose just a few things in terms of who these community health workers, and I think this is important when you're talking about mobile technologies and how to assist them. They are trusted community members. They're volunteers. And so they're also not part of the informal health sector. They're unpaid. And they receive very short healthcare training. So they don't go through the formalized training like the other health workers in the facility. Next. And some of the challenges, and this will be tricky because I have several animations on this one. Next. They have multiple roles and demands. Of course, they for example, in Tanzania, the community health workers that we're working with are providing reproductive and child health services. So you can imagine they're providing family planning services, antenatal care, they're providing HIV, STI services, of course, limited, not the full range of services, limited to their levels. So they have multiple roles and demands. Next. They lack appropriate tools. The picture that you see in the center there is a flip chart, so for family planning services. They have several different tools for these different health areas. And they also have several paper-based recording tools. So you can imagine if you have to walk around the community all day and seeing different people and having to carry this many paper-based tools. Next. They also have weak performance incentives. As I said before, they are unpaid, and they receive non-monetary incentives like bicycles and gumboots. So, they're doing this on a voluntary basis, and so their performance incentives, in terms of being able to achieve high output is particularly low, and we, as a result, see a lot of attrition rates as far as community health workers are concerned. Next. And they also, of course, receive limited supervision. So the question for us, the challenge, I guess, that was posed to us, next slide, was could mobile technology support their work? What will mobile technology be able to do to support their work was the challenge that was posed to us. So we set out to develop a mobile tool to be able to basically do several things. Next, please. So this mobile health innovation, we're calling it EFP, and it's basically a mobile phone, next, with evidence-based tools. This is a Balanced Counseling Strategy Plus tool from Population Council, WHO Family Planning Decision-Making Tool, and a pregnancy checklist. It also has a bunch of data record forms that are requested by the Ministry of Health. And then what results is the phone with an algorithm on the right side here, which we are calling EFP. Next. Now, our tool has 3 technological components. It's an application which has the integrated algorithm. It also has GPRS. It's basically on a feature phone. It's not a smartphone. So the GPRS enables for the data transfer from the CHW mobile phone all the way to the central database system. And then it also has SMS for a reminder system. Next, please. So the technical functionalities in the context of health is that the integrated algorithm enables the community health worker to counsel, screen, provide, and refer as well as follow up clients. For family planning services, HIV, as well as sexual and transmitted infection services. It has the data form, which allows that to record and submit client data, as well as a reminder system, which also functions as a management tool for the community health workers. So, for example, they receive a reminder for follow-up visits for their clients on a weekly basis. They receive reminders for getting a resupply for their commodities, etc. So different kinds of reminder systems. Next. Some of the technology advantages that we see for EFP in our work, includes the sequential steps and the skip patterns that it offers. So, for example, if, for example, a client is screened, enters through the registration that they are above 35 years of age and then chooses oral contraceptives and then says later they're smoking, they will be deemed to be medically ineligible. It also has auto data capture. So, for example, if it's just referring clients, it will just enter as number of referral. The CHW doesn't have to manually enter how many referrals they have issued for that day. We also have real-time access to data, which was not there before completely, as well as the reminder system. This is particularly important because we have a high rate of loss to follow-ups. And of course, for the CHWs in particular, is portability, because they move around a lot and they need something that they can easily move with. Next slide, please. So we have several research questions, and I do apologize that I will not be able to present any results for this study because we're just deploying the study right now. But at least I'll give you an overview in terms of what we're thinking. So we have 3 research questions that we're looking at. The first one is feasibility. Is it feasible for the community health workers to use this tool? The second question we're looking at is, does it lead to efficiency gains, especially when it comes to data records and submissions, etc. And then lastly, is it effective to improve outcomes? Those are three things that we're looking at. Next. Our study design is a randomized control post-test only. We're working with 6 wards in Dar es Salaam district, and we're randomizing 3 into the phone job aid, and then 3 wards to a paper-based equivalent of the mobile job aid, and we're doing a baseline interview before we deploy the intervention, and then 4 and 6 months after we'll be collecting several levels of data to answer our study questions. Next slide, please. So some of our study measures that we'll be looking at for the 3 questions. For feasibility, we're looking at service provision, like number of client visits, number of follow-up visits, etc. We're looking at acceptability at 3 levels, community health worker level, at the client level, as well as the supervisor level. We're looking at cost, the incremental cost for deploying such an intervention in a setting like Tanzania. And then very importantly, we're looking at implementation issues, because what we're really trying to look at is trying to see how best the mobile job aid can fit in the existing system, health system, because we don't want to introduce a parallel system. So we're really trying to see what is it that facilitates that or inhibits that. Then as far as efficiency is concerned, we're looking at follow-up visit completion rate. Like I said, we are experiencing losses to follow-up. And then we're looking at data quality and submission rates as well, because we do have incomplete data record forms problems, as we all know, in the field. And then as far as effectiveness is concerned, we're looking at quality of counseling. These are just key things that I'm pointing out. We do have a whole list of measures that we're assessing under this study. Next, please. Okay, so as I mentioned before, we are almost deploying. We just received our ethical clearance yesterday after almost 6 months. So that delayed our process, but we've completed design process, usability testing, and we took a whole lot of time to refine, and that was very, very important. So we went back and forth to the field, testing and refining the tool. And then we'll be ready to deploy by January and then evaluate. I have a few data points to share with you from usability testing. Next slide. We tested this with 6 community health workers this year, and they saw 262 clients. 77 of those clients were female. And among those clients that they were able to provide family planning methods, 82% were given oral contraceptives. We found that 4% of those clients were pregnant. And then we have a risk assessment algorithm, and we found that 47% of our clients were at risk and they were not diagnosed for STIs and HIV. So this one is particularly important because when the phone job aid allows certain things not to be missed, like risk assessment, like identifying those people who can receive care and treatment early on. Next, please. As we have been working through this process, of course, we have already been experiencing certain challenges, and there are several things that we are considering that will be a challenge. And the key things so far are we are developing an innovation, but we're working with a weak health system. That's not going to change. So there are certain things that will impact our study results or may impact our study results and the extent to which our mHealth innovation works. For example, supply of commodities. We need to be able to have enough HIV testing kits and FP commodities. Those are things that we don't have control over, however good or great our mHealth innovation is. We've had to balance our technical and technological needs. Like I said, we're using a feature phone, which is pretty basic. And we do have a lot of technical demands with the algorithmic steps. You can imagine if some of you know, all the family planning, counseling, and screening steps that you have to go through. And then, so being able to balance that with a sort of basic phone in a way, can be challenging sometimes. And then, of course, we have scale-up and sustainability issues that we have to consider. We have been funded to design and evaluate the mHealth innovation. And so what's going to happen with scale-up and sustainability? There's certain costs that will need to be considered. How will they be covered? So those are the things that we are already considering at the moment. Next slide. So this is my last slide, and just basically saying that regardless of all that, we are very excited to get into the study, and we're very positive that we are going to get good results. And these are sort of our post-study steps. If the study results are positive, we will work on refining the algorithm based on lessons and field performance. We'll explore opportunities for integration in other platforms, as I think my next speaker will talk about EIMCI from Tanzania as well. We have several other mobile health innovations that there's opportunity for us to integrate this component in that, so that we don't have missed opportunities in other settings as well. We'll also explore vertical scale-up as well, because in Tanzania there are other settings that have community health worker projects, and then the Ministry of Health is very interested in having this adapted for facility-based stuff, so we're looking into that as well. Thank you. And my last slide, please. Thank you.
Great, thank you so much, Christine. All right, our next speaker is Seneca Perry. She's from D-Tree International, as Christine mentioned, and she's going to be talking to us today about the results of a communication enhancement used in EIMCI decision support for the treatment of children under 5, also in Tanzania. So welcome, Seneca.
Thanks so much for coming today, everybody. I just want to start out by thanking our amazing team of people that have worked on this project with us, from Harvard School of Public Health, our PI, Mark Mitchell, D-Tree International, Damagi, and Swiss Tropical and Public Health Institute. And this research was funded by the NIH. So next slide, please. So to start off with some background, although Tanzania has made significant progress in reducing under 5 mortality, the current rate in 2010 was 81 per 1,000 live births. So this is still high. And under 5 deaths are largely due to preventable causes, including neonatal complications, malaria, pneumonia, diarrheal disease, and HIV/AIDS. Next slide. So these health problems are the main components of IMCI, which is a clinical algorithm supported by the government of Tanzania. IMCI has been shown to successfully reduce childhood deaths when used correctly. However, there's good evidence that IMCI is in fact seldom used accurately or correctly in Tanzania and elsewhere, substantially reducing its effectiveness. And next slide. So propelling under 5 health interventions, including IMCI, continues to be a challenge. Among other problems, conditions of health workers serving low-resource populations include frequently being overburdened, undersupervised, and they're often lacking resources needed to provide clinical services. Among other problems this creates, the health education and counseling being provided in these low-resource settings often is of very poor quality. So this has resulted in critically low levels of health literacy among the low-resource populace. So this means that a large body of already marginalized individuals are often unable to leverage the resources that they do have. Next slide. So the Institute of Medicine Committee on Health Literacy defines health literacy as the degree to which individuals can obtain, process, and understand the basic information and services that they need to make appropriate health decisions. Next slide. So if we look at the full chain of health service delivery, we can understand why counseling and health literacy are so essential. Health service delivery begins with intensive scientific research and development, such as finding ways to diagnose illness and discover medications that can cure disease. Then these resources, such as medications, supplies, and knowledge, have to be disseminated to frontline health workers in order to be implemented through care and treatment plans. These elements are vital to any public health program. We believe, however, that the key to fundamentally improve under 5 mortality rates lies in the realm of client understanding through health literacy. It's only through this understanding that treatment plans can be correctly applied at home and a successful health outcome can result. Without this knowledge, caretakers can't fully understand how to implement the treatment plan at home, and the interventions that could save lives may fail. Next slide. So with this in mind, we designed a study with the goal of increasing caretaker health literacy. Knowing the advantages that mobile phones can provide, we hope to leverage optimal caretaker learning and provider communication through the mobile platform. We aim to build on the advantages that IMCI provides to further expand the impact of counseling for children's caretakers and result in better understanding of what needs to be done at home after the mother returns. Through this approach, we hope to build a mechanism that could later have a positive impact on under 5 mortality rates and improve health outcomes. Next slide. So we designed an intervention that emphasized the counseling prompts of an adapted version of IMCI. Providers in the test arm used mobile phones with the adapted IMCI that we programmed into a mobile application called eIMCI to guide clinical encounters with ill children under 5. The application included a 25-second video formatted for the mobile phone to educate caretakers. And then we also embedded the communication content into prompts given within and at the conclusion of the visit. Providers in the test arm then used the eIMCI application to guide their entire clinical encounter. Then providers in the control arm used an equivalent protocol in paper format that used the same counseling messages but were in written text as part of the protocol. So we demonstrated the equivalency of the two platforms in an initial study and then set out to find out the impact of the mobile platform in a typical clinical setting in this study. So we evaluated what we consider to be the 3 most important things that a caretaker should know when they come home from the clinical visit when they get home, including the diagnosis or problem of the child, the treatment plan and medications that they were to be given at home, and then when to return to the clinic if necessary. Next slide. So we used a randomized cluster design, and our urban sample was in Dar es Salaam and included test and control arms of 352 participants from 6 municipal clinics. And our rural sample was taken from the Ifakara region and had 360 participants from 6 municipal clinics. And then we had an observer record the type and amount of counseling delivered by the clinician during the visit, and then also an interview was held with the caretaker after they left the visit to find out what information they remembered after. Next slide. So for the diagnosis of the child, we looked at what, if any, problems were verbalized by the health worker and compared that to what the caretaker reported. A partial match was achieved if only some of the problems verbalized by the health worker were also reported by the caretaker in case more than one diagnosis was given. And then a full match was achieved if all of the problems that were verbalized by the health worker were also verbalized by the caretaker. So we have the red is for a full match, blue is a partial match, and then green is no match in the graph. So in our urban sample in Dar es Salaam on the left, using a chi-square analysis to compare differences between groups, we found that significantly more matches were achieved by the test group using the mobile application than the paper control group, with a p-value of 0.000. For our rural sample from the Ifakara region, again, we found that significantly more matches were achieved by the test group using the mobile application intervention than the paper group, also with a p-value of 0.000. Next slide. And then for the prescribed treatment of the child, we looked at what kinds of treatments, if any, were verbalized by the health worker and then compared that to what the caretaker reported. So in the urban sample in Dar es Salaam, we found that significantly more matches were achieved by the test group using the mobile application with a p-value of 0.000. And then again, we measured for no match, partial match, or full match. And then the rural sample of the Ifakara region, for this question, we actually found that there was no statistical difference between the groups, and with a p-value of 0.211. And as you can see, both groups actually did quite well for this indicator, with most participants achieving at least a partial or full match. Next slide. So then for the indicator of when to return to the clinic, we looked at if the health worker told the caretaker when to return in case of non-improvement of the child's illness. And for the Dar es Salaam sample, we found that when to return was reported significantly more times in the test group using the mobile application with a p-value of 0.000. And then finally, in the Ifakara region, that was also, when to return was also reported significantly more times in the mobile application group with a p-value of 0.015. Next slide, thank you. So our preliminary results showed that overall clinicians provided significantly more effective counseling to caretakers when using the mobile application in both of our urban and rural samples. So if the information was provided, caretakers were better able to recall the counseling they received during the visit and what they were supposed to do when they got home. Next slide. So we believe that this study shows how mobile technology can be used to improve counseling by health workers and result in increased caretaker health literacy. These considerations of health literacy are critical to improve under 5 mortality. And these results show that further research and intervention development is greatly needed to explore these implications and their related impact on health outcomes. And there's our references. Thank you.
Thank you so much, Seneca. We actually have a couple minutes for some questions for Seneca because she didn't use all of her time. So if there are any questions from the audience for Seneca, great.
Thank you. Interesting work. I'm John Bennett from the Atlas Institute at Colorado. Have you looked at the data to examine the differences you saw between rural and urban populations? And if so, could you comment?
We actually haven't looked at those comparatively yet, and so these are preliminary results, but we definitely plan to. And it is interesting where we did see the differences, such as in the prescription, that there were no differences between the paper and mobile groups there. And I think that we're going to have a good time examining the causes of that. I think there's some differences in the training between the two groups because in Dar es Salaam, we had a very large group of clinicians that we were training all at once, and we had moderators that were assisting to break everybody up into small groups, but it was really the first time that almost all of these clinicians had participated in a study and had used a mobile phone. We used smartphones for this. And so it was the first time that most people had actually been able to use a smartphone during their clinical care. And so there was a bit of a learning curve for some and not as much for others. But the large group setting definitely changed things, whereas when we went to the Ifakara region, we were able to spend, and that actually went for the paper group as well. So we had the large groups for the paper and the mobile phones, and it was a new algorithm. And in Ifakara, we had really small clinics. We had the resources basically to be more one-on-one with the clinicians on both groups. And I think that did potentially have an impact on the outcomes between the groups.
My name is Siddharth. I'm with the BBC Media Action. And my question is, or before the question, the context. So since I've been in mHealth for the last 2-3 years, I've seen a lot of RCTs. Mm-hmm. And every time I see the results of those, they're very impressive, like we saw today. I mean, everything that has been shown seems to work. So who is not convinced? Who is asking for more RCTs? When will they get convinced? And when will this go to scale?
That's a great question. I'm not sure who's not convinced yet. I guess we'll have to let them speak up and tell us. I feel like we did so much usability testing, which I didn't present in the name of time here, but we did a really thorough usability testing using systematic tests, very formal, and a ton of iteration in the field back and forth. And the development process actually took much longer than the actual data collection process for us. And so for our results, and these look good so far, they're also preliminary, so we may have more coming that don't look as good, we don't know yet. But for our results, it felt like we had a very close connection with our users, with our user test base, which were not the people that we included in the study. But I felt like that helped for our purposes a lot. So.
Yeah, my name is Eugene. I'm from Nigeria, National Primary Health Care Development Agency. My question is for my friend from Tanzania.
I'm sorry. We're just going to do all the questions questions at the very end. This was just because Seneca had a little extra time in her 15 minutes.
That's okay. Though.
Okay.
You can go ahead if you want.
Okay.
You can go ahead. I'll have you say.
Yeah, well, I was, we're trying to do something similar in Nigeria, and we have this issue of incentives for the population. You have incentives for health workers, you give them bicycles and all that, so they're kind of committed in doing their work. We have a problem of getting the communities to actually participate in the use of mobile technology, particularly like when it comes to issues of registrations and all that. So I wanted to know if you had, in Tanzania, you have incentives for the population. Then your community health workers in Tanzania, you said most of them are volunteers, and I was wondering really what level of education do they have, and what time do you take in training them on the use of the mobile technologies? Thank you.
All right. Okay. Can you hear me? Okay. So the first question was whether we provide incentives for the population. For this mobile job aid, we actually don't. The mobile job aid is not used by the population; it's used by the community health workers. So there's no incentive for the population in particular. So it's just used for by the community health worker to counsel and provide services to the population. So there's no incentive there. But we do have another mHealth innovation, which is for the population. It's called M4H, and we don't offer any incentives for the population, and they adopt it naturally. As far as level of education for the community health workers, there's no minimum. There's a minimum requirement. It's standard 7 for Tanzania, which is primary school completion. And then for the time for training on the mobile technology, right now our training curriculum is 5 days that we're working with. And it's really just focusing on how can they use the tool. So it's not on the actual health areas like family planning, etc., because they've already been trained on that. They're practicing that already. Yeah, thank you.
And I think for our colleague from the BBC, there's some interest in further discussion on that by the whole panel. So after our next speaker, we can maybe go back and revisit that. So thanks for bringing that up. All right, last but not least, we're going to hear from Bill Teese from Microsoft Research India, and he's going to be talking to us about an automated voice calls to improve adherence to iron supplementation during pregnancy. And this is a pilot study in urban India. Thanks, Bill.
Thanks very much. Thanks for having me here today. So I sit in Microsoft Research in Bangalore. And for those of you who aren't familiar, Microsoft Research has a group in India that looks very broadly at the role of technology and global development. And a lot of our long-term projects are in healthcare. So we've worked in detail looking at tools for health workers to gather data, what's the right user interfaces for health workers and patients to interact with computer or electronic technology, what are even more qualitative insights about patient attitudes towards health-seeking behavior. And recently, a lot of our work has looked at voice systems over mobile phones to either collect or disseminate information to patients. And since this was a short talk and without a full peer-reviewed paper, I thought I'd take the opportunity to describe some work in progress, kind of an early result that hasn't yet appeared in print, but it's also a result that I'm very excited about and looking for collaborators and for feedback. So the project today is to look at iron supplements during pregnancy to try to reduce anemia in pregnant mother. And we have some early evidence that suggests maybe voice reminders could help with this process. This is joint work, especially with Naranjan Pai and Pradmya Supa, and advisors Dr. Shailesh Kore, Nandawanar, and Aparna Hegde was an early instigator of this project as well. Next slide, please. So our context today is maternal anemia in India. Almost 90% of women in India are anemic. And this contributes a large degree to maternal mortality and also to the health of the child. So it contributes to miscarriage and stillbirth and just your trajectory as a healthy infant as well. Now, the most common cause of anemia is an absence of dietary iron. And the good news is often there are supplements available, especially in urban hospitals, can give you iron supplements during pregnancy, and often those supplements are free. So then what's the problem? Why don't you just take the iron supplements? Next slide. Turns out adherence to medication, in this case iron supplements, is a very complex sociological problem. There are lots of factors at play. In some cases, there's not good supply of medication. We won't focus on those problems today. Often there's a poor relationship or absence of a relationship with a care provider. Anemia is one of those conditions that's not always acute. If you as an individual and also your peer group are anemic, you don't necessarily go seeking care. That starts to be part of your expectation of your health. So you need a proactive care provider who's actually convincing you to undergo treatment, and that relationship is often missing. There's negative perception of iron pills. They're large, difficult to swallow. There's a perception they might make the baby too strong, too big, have a difficult delivery. Actually, sometimes if you convince them it's good, maybe the man in the household takes the supplements. We've seen this happen. Oh, it'll make me strong. Why make baby strong? So the interesting perceptions that come. Or could contribute to dark skin, for example, is undesirable in Indian context as well. So you have to work against those factors. Forgetfulness is also there. If you're committed at the beginning, oftentimes you're not committed throughout. And side effects sometimes, although if you look at the literature, often side effects is not as much of a contributor as some of these other factors in the context of iron. Next slide. So, if this is such a big problem, next slide, researchers, of course, have looked at medication adherence and adherence to prescriptions in general for a huge amount of time. These are all reviews of literature that try to look for good interventions to improve patient adherence to doctors' directions. Next slide. In fact, there are so many that they've written reviews of the reviews. As a computer scientist, I find this astonishing. We hardly have any subject with a rich enough literature to even attempt such a paper. Next slide. So what does the review of 38 systematic reviews find? Next. They actually find that although successful adherence interventions do exist, half of the interventions do seem to fail, even by researchers that are trained in the field. And non-adherence rates in general across many diseases have remained largely unchanged across the past several decades. Good. So then what can we do? So we saw there were some successes, and often the successes are multifaceted. So there's no silver bullet. That's one lesson you should learn. You won't find one secret. It would be very rare that you can tweak a single thing and have a big outcome. But surrounded by the right context of health infrastructure and well-intentioned people, sometimes technology can amplify the effectiveness in that context. And if you look at what's been done with mobile phones, lots of people have done text message reminders to improve adherence to medication. And actually there's a review of already 25 studies looking at text message reminders, many of them in the developing world, and they've shown a lot of significant results for improving outcomes. Now, one big limitation there, especially in the context of low-income India, is that text messages still doesn't reach the really low-income segment. So still in India, 1/3 of adults are non-literate. Even if you're literate, it might be in the local language, and you might not even have local language font support on your phone. I live in Bangalore. Lots of the popular phones, especially for lower-income crowd, are imported from China. They certainly don't support Kannada, the local language, on a regular basis. So if you're relying on text, you're really going to leave out a large part of the population that you're interested in. So the next natural medium you would consider is a voice medium. Lots of people, still communicate with using a phone to actually talk. And so people have looked as well, can you use actually voice messages to improve adherence to medication? And there have been positive results there, but most of them do not look at biological measures, and they do not look at low-income populations. So they've shown, like in a Western context, you're more likely to show up for your dental appointment if you get a voice message reminder. You might be more likely to finish an immunization, to quit smoking, things like that. But with very few exceptions, they haven't looked at strong biological outcomes, which is the evidence I actually think we really need, and we can come back to this conversation on the panel. So next slide. Our research question was to see if you can use automated voice reminders to have a measurable improvement in blood hemoglobin in an intervention group with a very low-income population. So we focused on lower educated and lower income women in an urban Indian context. This was in Mumbai. They were not familiar with SMS, by and large. We did focus on women that owned or answered the family cell phone. So that's still not everyone out of our candidate pool, but that fraction is growing every day. And especially women that work outside of the home, if they're a maid, if they're a cook, they frequently have their own phone. And we were focusing on the issue of actually adherence as opposed to medication supply, which we'll come back to later. Next slide. So how did we design the study? We partnered, we as Microsoft is not a medical institution, so we found a local hospital in Mumbai. Sion Hospital is actually a big government hospital, very well respected, located right next to the Dharavi slum communities. So they have a lot of low-income patients that they're always dealing with. We enrolled 150 women, split across 2 conditions. In the control group, there was just a counseling session with a doctor. So we wanted to make sure they had the benefit of a good provider relationship, even if they're not getting the technology. In the intervention group, they also had voice messages delivered 3 times per week to encourage them to take medication. We measured the hemoglobin levels in the blood using an autoanalyzer before and after 3 months of these interventions. Next slide. So I want to say a little bit about how we designed the voice messages. So this is a part we gave a lot of thought to, and I'm very happy with kind of the outcome. We had 30-second messages that were repeated twice on each phone call, and we really tried to make the experience as personal and as trusting as possible for the recipient of that call. So for starters, we played it in the language of their choice that they specified at the time of enrollment, giving the 2 major local languages as options. We customized it to their stage of pregnancy. So for example, every week it might say, this week your child is developing a nose. Congratulations. To actually ensure a healthy pregnancy, please, don't forget the iron supplements. We actually stored the phone number of the automated dialing system in their phone at the time of enrollment. So their phone rings, they know it's the hospital calling, less likely to reject the call. And in fact, we recorded each message in the voice of that doctor that they met. So it's not a spam phone call. They have a personal connection. We have other research that shows patients are much less likely to hang up if they know the voice that's calling them. In fact, sometimes they think it's the live human being, even later down, excuse me, sir. Oh, please say that again. Oh, wonderful, sir. Yes. Bye. We also delivered the messages on the day and times of their choosing, so it's convenient for them personally. And if you're a speaker of Hindi or Marathi, I have lots of messages I'd love to play for you afterwards. Next slide. So what was the outcome? How did we execute the study? So we enrolled women successfully. Turns out an unforeseen challenge for us was bringing sufficient women back for the follow-up checkup. We anticipated this to be difficult, but not as difficult as it was. So we only followed up with 87 of the women in our sample. Turns out, it's easy to lose track and touch with women in your sample. Actually, in India these days, people change their phone number every few months because you get different deals from mobile operators all the time. And so there are so many more SIM card connections than there actually are people with those connections. It's really tough to maintain an identity. Also, people go to their native place, all kinds of challenges. The demographics amongst the people we actually ended up following through, they were balanced across the groups. On average, our women were about 24 years old. They had about 7.5 years of education, and many of them, that means they were low literate, especially when it comes to, technology usage, definitely no English literacy, and so on. They were about 16 weeks into their pregnancy when they enrolled, earned about $130 per month, so these were usually maids, cooks, auto drivers, that kind of population. And it was a moderately anemic group. So WHO qualifies anemia as less than 11 grams per deciliter. On average, we were at 9.6. Severe anemia is down around 7 grams per deciliter. So we had some variation in there, but it's in the middle, kind of moderately anemic. Over the study, we placed about 3,700 phone calls, not counting retries, and most of these calls were answered. So 72% of the calls were answered. And remember, a lot of these numbers didn't even correspond to real women anymore, so you have to wonder, the person that got the new phone number, what they thought of these calls. Answered calls still lasted at least 40 seconds, so on average 40 seconds. So that means most people listened to the full message, and lots of people listened twice. So we streamed, good 30 hours of audio in these 3 months. Next slide. So what was the impact on hemoglobin? Next slide, yeah. So I'll show you a histogram. I'll show you counts of patients that had a given level of change in their HB level. So if you're further right on this graph, you're doing healthier during the course of the trial. In the control group, you would expect to see a balanced distribution. And actually what's surprising here is you see a huge amount of variation in the control group. So, people are changing, even going down by 3 points of hemoglobin during the trial, which is something else we could talk about. But that's centered, next slide. On average, the control group had slightly lower HB. Now, the treatment group you would hope would shift this curve to the right. And next slide. What we see is a very minor shift in this initial trial that we ran. Next slide. So on average, the HB levels gained by about 0.27 grams per deciliter. So this is of, marginal clinical significance. And actually, we don't, unfortunately, have statistical significance, even in the increase in hemoglobin amongst the treatment group by itself. And that's partially due to the sample size that we ended up with. It's also because we weren't as vigilant as we should have been about ensuring access to iron pills. So we later learned that some women had difficulty refilling their prescriptions that were not fully prescribed at the beginning of treatment. At the same time, I think one important part of the conversation is not just the effect size, but what is the effect size per unit cost that you're investing? And here the cost was pretty marginal. We're just paying for the airtime of making these phone calls, so that was about 20 cents per patient. And, that's about 3 or 4 iron pills in terms of the reminders that you give. So if you get them to take 3 or 4 pills, you're basically, in some sense, breaking even there. And so you still might want to undertake such an intervention, even if you're not sure every patient would benefit. So where do we want to go from here? So again, I said this is early work, and we would never want to kind of close the book on this subject in the current state that we have. We're excited, and we're working on replicating this study at a larger scale. We want to have a larger sample size, see through better supply of iron supplements, and also I'd like to compare to a live human being. I think this is done much too infrequently when you're studying technology relative to a control group. How good could the technology possibly do? We want to get that doctor to make live phone calls to the patients at some increment and see if any force of nature can get these women to actually take the pills and how much you would increase under that kind of oracle situation. We actually started that condition, but we didn't finish it this time. We're working to scale up the service as well. So Aparna, one of the co-authors, is leading an initiative called mMitra at an organization called Arman, where they're funded already to deliver these kinds of messages at scale to whole states in India. So that'll proceed in parallel with the rigorous evaluation. And the last thing I'd like to say is something interesting that grew out of this project is we actually realized how difficult it is to build good interactive voice response systems to do these kinds of trials. And there are lots of parallel efforts going on, by the way, I should have mentioned. Please visit the other maternal health sessions during this conference. So there's great stuff from Grameen Foundation, MDill is here, Damagi has some stuff in flight, and so you should see what they're working on. But one thing we realized is that it would make a big impact to make it easier for organizations to set up and host interactive voice response servers. So at Microsoft, we actually built a system. It's open source. It's free. We're trying to partner with organizations to help them use it. It's called IVR Junction. You can find it on the web. And we're using that to replicate and scale up the service. So I'll look forward to your questions. Thanks.
Great. Thank you so much to our 4 speakers. So now we're going to open it up with the rest of our time for more questions. And actually, before there's any more questions, I'd love to open it up to the panel, the question that was posed to Seneca after her talk from our friend from the BBC about sort of the need to do more RCTs. So, yeah, absolutely.
I think a very appropriate question, and it's one that at this conference, the 4th mHealth Summit, we're really dealing with across multiple panels and across multiple discussions that are being held both on and offline during the conference. For governments and large implementers to make decisions as to which of these solutions are implemented at scale, there are a number of value propositions beyond the mere randomized controlled trial evidence of efficacy that seem to be required. And you have to remember that we're dealing with a context where resources are very limited to make decisions about investments in infrastructure that these represent, especially when you're talking about system strengthening innovations that work at the provider or the health systems level. So issues about costing, there's very little evidence right now that we have in terms of what are the true costs, both direct and associated costs of scaling these strategies. What's the value proposition in terms of deferring other investments in the health sector that these investments might represent? And then speaking about the formula for scale, I mean, what are the supporting systems that need to be in place to ensure that the technology itself can go from 1,000 users to 100,000 users in these rural remote populations, where often simple things like troubleshooting a menu or making sure that a battery failure doesn't stop the workflow of a health worker are still issues that haven't been fully resolved. So we're really talking about implementation science now as the big frontier for figuring out how do we take effective solutions and scale them. I think the BBC experience is one that has reached substantial scale, but I think there are factors about the strategy that the mobile Kunji system has used that allows it to scale that irrespective of these other forces. So we can talk about that after the session as well.
I actually think you answered the same thing that I was going to say, other than the fact that what I wanted to add is, I think in particular for us, we had a choice to use different study designs, but this was also of interest to us because we did want to have to use a very good study design to be able to convince even the local government as well as other stakeholders, because this mHealth innovations are new in the context that we work in. And so it is important, it's as they say, disruptive technology. It is important to be able, if you can use the most rigorous study design, use it. And you can actually do so at low cost. It doesn't have to cost so much to do an RCT study.
Define my question because
No.
I don't want to get the typical responses that you get every time.
Sure.
So, I think my question is more specific to the kind of work that Dietrich and Demagi are doing, where they're using handset apps, which are very similar across the multiple geographies that are where these RCTs are taking place. So, what CARE is doing in Bihar is very similar to what's happening in Tanzania, and so on and so forth. So, my question is, why can't Demagi just say we've done it? It's been tested in at least 2 or 3 geographies, it works, let's move on. And the other point is, I have been selling ideas and innovations to government for the last 10 years. Show me a government officer that relies on research data to make decisions. I haven't met one till today. They either like the idea or they don't. I think it's the academicians who are interested in research data, it's donors who are interested in research data, and I think somebody has to now stand up and say, okay, we've proved this and this and this, what do we need to prove more? Because the RCT that you're doing in Tanzania is exactly the same as the RCT that's being done in Bihar, for example, and in many other places, and you're testing the exact same parameters of the problem, not even different parameters. So I think we have to get more specific.
So I think to some extent we've created our own Frankenstein monster, because for 3 decades now we've been drumming home the basic strategies to ministries of health and to decision and policymakers about what kinds of evidence are useful and valuable in taking policy level investment decisions at a government level. I think you'll be happy to hear that WHO has, as of this year, we'll be having our first meeting coming up in next week, for a mobile health technical advisory group that will begin to synthesize all of this information that you've rightly brought up and provide the kind of guidance that governments are looking for to make those strategic investments. So I think we have to learn to speak the language that those policymakers are looking for in order to make those strategic investments. And I think the ecosystem has matured to the level where we're learning now to have that cross-sectoral dialogue. So hopefully we'll see some good coming out of that.
Add to that a little bit. Okay. Actually, we I agree with you exactly what you said, that we don't have to repeat the same study over and over. And we really wish that was the case. And we had worked in this context several years, and in particular in Tanzania and other countries as well. That's not the case. Even a study that's done in Uganda or Kenya, they still want it to be repeated in Tanzania, because what they say is that the local context is different. So we face that not only in this case but in several. And with regard, now I've lost my trail of thought. So I'll let you Bill say something, and if I remember. Yeah.
Well, I think that is this one on? Can you hear me? Yeah, okay. Oh, sorry. I think that these are really great points that are made, but I think we have to remember too that it wasn't very long ago that there weren't any published RCT studies with mobile health. And so this is all, everybody's kind of coming out with their results right now all together. And so it is the right time to be looking at all of them together and coming out with new policy. But it's been a process that's been very necessary. And so it is exciting to be at this point now where we can kind of take those results and start making policy changes. But it's been a natural process, I think.
So I agree with that and what Alan said about role of RCT eventually in policy. I think one thing coming from kind of human-computer interaction perspective and methodologies you see in computer science is that there's another role for a set of evaluation techniques that don't necessarily have to have policy relevance, but can shape the direction of your own research agenda, either to help you fail quickly, which I think is one danger you often see with RCTs. There are RCTs that shouldn't have been done because they should have failed that project earlier, either with a smaller sample size or with other techniques that showed, you don't need to spend the money on a huge RCT. And so I think maybe I'd modify the point. You don't need a large-scale RCT in every situation. There are roles, this is part of what we're doing in what I presented. Convince yourself that you're on the right path and do more of an adaptive trial design to figure out the right sample size, or other methodologies, if it's design or focus groups, getting richer sources of data to help set your own path before it comes time making the case to the governments. Yeah.